Good morning. Today topic for discussion is breath holding spells. I am Dr. Tangella Manasa, Senior Resident from the Department of Pediatrics. So breath holding spells are common non-epileptic paroxysmal events in children which occurs for less than 1 minute. The term appears to be a misnomer as the spell is a reflex occurring involuntarily during expiration. There are three types of breath holding spells: cyanotic, pallid and mixed. Most common is cyanotic. It occurs between the age groups of 6 to 18 months. Affects 4 to 5% of pediatric population. Spontaneously disappears by 5 years of age. A male is to female ratio is 3:1 and it has positive family history and it is an autosomal dominant. Idiopathogenesis is usually multifractional and exactly unknown, but it is known to happen because of autonomic dysregulation, where in cyanotic spell it occurs due to sympathetic overactivity, where there is inhibition of respiratory efforts and abnormalities of pulmonary reflexes, which leads to VQ mismatch and leading to cyanotic spell. Whereas in pallid spell it is due to parasympathetic overactivity, which leads to bradycardia and transient asystole, leading to a pallid spell. So age of presentation is between the months of 6 months to 5 years. It usually disappears after 5 years of age. Crying and pain are the most common triggering factors. Cyanotic breath holding spells are most common. The child usually emits a short and loud cry leading to sudden involuntary holding of breath in forced expiration. Then child becomes cyanosed. So the child becomes rigid and limp followed by transient loss of consciousness. Child may also throw seizures if apnea is prolonged. The pattern is stereotyped and it terminates with cyanosis followed by long inspiration and resolution of cyanosis. So pallid breath holding spells are more often precipitated by the pain. Crying may be minimal with brief apnea, often by a deep gasp followed by a loss of consciousness and posturing. The episode proceeds in same manner like cyanotic spell, except the child here develops pallor rather than the cyanosis. In both types, the entire episode lasts approximately for 10 to 60 seconds. Episodes lasting for more than 1 minute are very unusual. So what are the differential diagnoses? Epilepsy, sudden breath holding during sleep, shuddering, hypereclepsia, sepsis, and laryngeal stridor and whooping cough. So it is very important to differentiate seizure from the breath holding spell. Age of presentation for breath holding spells is usually infants and toddlers, whereas for seizures it can occur in any age group. It is often familial in seizures, even in the breath holding spells. Provoking stimulants are usually absent in case of seizures, whereas in breath holding spells it is almost always present. Sleep relation is never seen in breath holding spell, whereas it is often associated with seizures. Stereotyped episodes are always seen in breath holding spells, less common in seizures. EEG changes will be usually normal in breath holding spells, whereas it will be abnormal in seizures. So evaluation and investigation. Diagnosis of breath holding spells is usually by clinical diagnosis, and it is based on suggestive history. And as there is no confirmatory test, a careful physical examination should be performed to exclude other diagnoses. Complete blood count and serum ferritin should be done in anemic children. ECG should be considered in children with severe breath holding spells, mainly pallid spell. It helps to rule out prolonged QT syndrome. So what are the complications? Breath holding spells can be very distressful for parents and may have an adverse effect on the quality of life. Many parents with frequent breath holding spells, kids usually suffer from anxiety and major depression. Breath holding spells for the child is a benign and no sequelae are expected. Child will have normal intelligence and normal neurological development. There is no neuronal damage seen. The incidence of epilepsy is similar to that of general population. So what is the management of breath holding spells include educating parents and how to intercede before the episode progresses and the child becomes very distressed. Parents should help their children internalize the controls they want the children to exhibit. So it is usually reassurance. So there is no definitive pharmacotherapy. Iron supplementation should be done in anemic children, and even though if child is not anemic, it is known to have a good role if iron supplementation is given. Piracetam, a cyclic derivative of gamma aminobutyric acid, has been effective as a prophylaxis. It started at the mg of 40 mg per kg per day in children with severe and repeated breath holding spells. Many children with prolonged asystole associated with frequent and severe pallid spells have been treated with atropine to antagonize vagal hyperactivity. Refractory cases need cardiac pacing. Breath holding spells are frightening events that occur most commonly in healthy children between 6 to 24 months of age. So confident reassurance and family education are the cornerstones with iron therapy. Usually kids have normal intelligent coefficient with good prognosis. Thank you.